Hi, welcome to Endometriosis A to Z for all ages and all stages. I'd like to introduce our guest today, Dr. Larry Glazerman. He's a veteran OB-GYN with nearly 5 decades of experience. He earned his MD from Jefferson, which is now Sidney Kimmel Medical College in Pennsylvania, and completed his OB-GYN residency at Lehigh Valley Hospital. He has advanced certification in laparoscopy and hysteroscopy and is an advocate for MIGS. He served as an associate professor and director of MIGS at the University of South Florida Health. Welcome to our podcast, Dr. Glazerman. Thank you for coming on.
Thank you. Thank you for having me. I was just going to say, Carolyn, real quick, it's not that it's a big deal, it's Lehigh Valley.
Oh,
But
okay. I'm sorry.
She said it the Canadian
Oh, by
way.
the way, and
Yeah.
it's probably not
But you said A to
endometriosis
Z
A to Z.
also.
It's A to Z.
Right.
Right, exactly. Well, I thought you chose to say A
Yes.
to Z.
Yeah. Well, it's hard. I'll get called on it later. Actually, I think what we're going to talk about today is your specialty in therapeutics, Dr. Glazerman, and what can be done to provide care and reduce symptoms for women who have endometriosis. So I'm going to let you guys, answer to that. And that's sort of what I'm listening for.
So Larry, let's start with, I think, the very basics, and that is there are so many different medications that have been suggested to treat endometriosis. Where would you stratify them in terms of when would they be used? What's the mechanism of action or how one works versus another? And where would you start with one and then switch to another? So if we can start at that basic level.
Well, I think the first point, Mark, and you and I have had this discussion, it's very important. I don't think yet there is a medication that treats endometriosis. It's really important that we clarify that all of the medications we have now treat the symptoms of endometriosis. And that's very valuable and very valid. But we get a lot of pushback when we try to suggest that these medicines will treat the disease. They may or may not, but we don't know that yet. So having said that, I think the first level of medication that we have right now is very simple things. And the two simple things that I'll mention, I'm sorry, let me back up a little bit. The main symptom that we are treating is pain in its various iterations, whether it's menstrual pain, which is one of the most common symptoms, pain between menses, pain with bowel movements, generalized pain, etc. So what we're generally treating is the pain of endometriosis. So first line treatment is pain medication, non-steroidal medications like Advil, Nuprin, Aleve, etc. And very often they will work for patients with either suspected or proven endometriosis, and they will help the pain, quality of life. Next level would be the start of the various hormonal options that are out there. Typically either progestins, and progestins are compounds that are like the natural hormone progesterone, but aren't actually progesterone, and combination birth control pills. And those medications will work for a significant number of patients. And there are a lot of patients they won't work for. And the nice thing about both the nonsteroidals, or NSAIDs as we call them, and the hormonal contraceptives are that they're readily available, they're cheap, and they tend to work for a lot of people. If those things don't work, we move on to the next level of hormonal treatment. And those are the GnRH class of drugs, which have gotten a lot of publicity, both positive and negative. But for 30 or 40 years, we've had some GnRH agonists, things like Lupron, which a lot of people are familiar with. The biggest problem with Lupron is things like hot flashes and bone loss. Lately, and the other problem with Lupron is it's an injection. And I don't need to get into the mechanism of how it works, but because of the way it works, it often causes a flare of symptoms before you get the reduction in symptoms. The newest generation of hormonal medications are the GnRH antagonists. And the ones commercially available out there are two in the US called Orilissa and Myfembree. Orilissa is a pure GnRH antagonist. Myfembree is sort of unique. It's a GnRH antagonist that also has some estrogen and progestin add back. And those things have been shown to work very, very well, again, for the pain associated with endometriosis.
So before we get further with that, Larry, we've got a lot of alphabet in here.
Yes.
Explain, when we talk about GnRH antagonists, what does it actually mean and what is it doing?
That's a great question, Mark. And I did get a little bit far afield with that. GnRH stands for gonadotropin releasing hormone. Big words, big letters. It is GnRH is a hormone produced in the pituitary gland. In the hypothalamus, which is a part of the brain, which stimulates the pituitary gland to produce a hormone called FSH, or follicle stimulating hormone. That in turn stimulates the ovaries to produce estrogen. So that was a long-winded way of explaining how a GnRH antagonist, by cutting down the secretion of GnRH, eventually decreases estrogen levels. And it has been shown time and time again that decreasing estrogen levels can help with the symptoms of endometriosis. So the goal of the GnRH antagonists, and even the agonists in their own way, is to decrease estrogen levels.
Great. And so, of course, one thing I think that's important for everyone to understand is that the difference between a woman who has a tendency to endometriosis as opposed to those who never develop it is that there are different estrogen receptors on their cells, their endometriosis cells. There's A and B, and A is kind of like a very mellow receptor that gets mildly stimulated. And the bad one that the endometriosis patients have is an estrogen receptor type B, which is like the crazy one. It's like thousands of times more sensitive and causes a whole lot more reaction than the B. Do these
Than the A.
GnRH
Than the A.
antagonists, right, than the A, do these GnRH antagonists work equally regardless of your receptor?
Well, I'm not sure how important that is because the estrogen receptor B is so much more active. Any effect on the B is what you want. So they do have a significant effect on the estrogen receptor B.
Great. And I'd like to take you back to the very beginning.
That's what I wanted to go back to, Mark. So can I just interrupt, just to go back to, actually jump back to progestins and hormonal contraceptives. So just from a patient point of view, what age is that appropriate to start? Is it safe? What are the symptoms of it? And when should they decide to move to some more advanced therapy?
So that's a really good question. And anyone who menstruates is a candidate for either progestin therapy or combination oral contraceptive. Yeah. We've used them. I'm not a pediatric or adolescent specialist, but we've used them in very, very young, and I will say girls, because they are girls, not yet women. And they're very, very, very safe, except there are certain women who can't and shouldn't take estrogen specifically, but for most women, these are very, very safe and effective.
Okay. And then do they have symptoms as well associated with them? Sorry, Mark. Sorry. I just want for everyone
there's a very important point I think I'd like to make here, and that is, right, when we're talking about the symptoms, Larry, what you first talked about was women with pain. But what about those who don't have the pain, but instead just have very heavy menses as their representation?
Well, the first thing I'll say is that presentation is not incredibly common with endometriosis. Having said that, as an OBGYN, yes, both progestins and combination oral contraceptives are very, very effective for heavy menstrual bleeding. But again, heavy menstrual bleeding without pain is not very common at all in the setting of endometriosis.
Okay.
A very important point. That now going back to the very beginning,
A very good place
We-
to start.
a very good place to
Okay.
That was
start.
Julie Andrews.
We know that in the U.S., we'll just talk about the U.S. for a second because I have the stats there. We know that in the U.S., there's about 1.1 million new adolescents that enter into that age group every year, and therefore who are at risk for what could be endometriosis, but we'll call it the pain of menstruation or dysmenorrhea. That's the official term. Um, when you use a prostaglandin inhibitor, as you mentioned, um, does that tell you that someone has what we call primary, just like pain due to cramps that you'd expect when the uterus is cramping and you're having your period, or is there a differentiation to what we would then call secondary, which is to say the pain is due to endometriosis?
That's a really good question. And it's a tough one to answer because clearly those prostaglandin antagonists work for primary dysmenorrhea, but they will also work in some cases for secondary dysmenorrhea. I mean, it's clear, and I'm sure we'll talk a lot about this over the next several minutes or whatever, but every patient is different. And it's really, really important to individualize. And I've said all along, and this is a little bit, maybe a little bit controversial, but Mark and I have had this discussion a lot. I don't care if a patient has endometriosis. If she doesn't have any symptoms, then, and again, this is like out there, but so what? We're looking for quality of life. We're not looking to check a box in a diagnosis code, so to speak, unless we need to improve the patient's quality of life. Endometriosis tends to do two things. It causes pain. The other one we haven't talked much about, and there's not as much, different data about, is infertility and pregnancy complications. And that's another area that Mark and I have started to get into a little bit, is treating, and I'm going to contradict something I just said, that we know that endometriosis is significantly related to pregnancy complications. So it's very possible, although relatively few studies, there are a few out there, that treating endometriosis, even without pain, may help prevent those pregnancy complications down the road. I see Mark smiling because he and I have had this discussion.
Well, and it's an important point. And again, I'm going to put a number on it just so people have a perspective. So again, US statistics, I can pull them up for every country, but every year there are 1.5 million de novo pregnancies, which is to say women who are pregnant for the first time in their life. And so you're talking about the risk of the ability to identify and potentially guard against what is one of the main causes of maternal or fetal mortality, bleeding, miscarriage, and preeclampsia especially, which is supposed to have a very high association with this undiagnosed endometriosis.
That is true. And that is absolutely true. Relatively new data, really, really exciting.
So what you're saying for women is it would help them if they knew during their first pregnancy or even before they started trying to have their family, like if they're choosing a midwifery clinic versus seeing an OB-GYN. Like you want to be in a hospital with an obstetrician if you have endometriosis because you're far more likely to have problems in pregnancy. This is sort of part of the conclusion or take home for women?
Well, yes and no.
Yes.
I certainly don't want to put down our friends, the midwives.
Yeah.
Midwives are great. The best midwife practices out there have a very, very tight relationship with OBGYNs and high risk OBGYNs and high risk units and whatever. So to modify your statement a little bit, Carolyn, I would say that if you are known to have endometriosis, you definitely want to be in a situation where those higher levels of care are at least available to you.
And I think what this introduces is the concept of screening, right? So screening, we have to be careful with the use of the word. When we talk about screening, let's say screening for HPV, that's a true screening because you don't know who has it, and it has significant complications like cervical cancer unless you identify these people early. That's true screening. And so with endometriosis, people have never really talked about screening, but when you think about the high rate of complications caused by silent endometriosis, which is probably 15 to 20% of disease, probably.
Probably.
Then now we're talking about, should we be screening all women for their first pregnancy to see, do they fall into a increased risk category, just like with any other thing we screen for? It's a controversial question, but I think we're coming up on that.
Well, and I think part of the problem, and again, this is leading into other things I'm sure we'll probably discuss, is until now, we haven't had a very good, simple, easy, quick, inexpensive screening test for endometriosis. And until now, the only way to diagnose endometriosis definitively has been with a surgical procedure. And you certainly don't want to subject women who have no symptoms whatsoever to a surgical procedure, which in and of itself carries its own risks, although small, for something they might not even have. So this is leading to where I'm sure we're going to go in this discussion that, screening for the disease can have some incredible benefits.
That's one of the questions I was going to ask. I'm just going to go right into it. Like, how can you see rapid and non-invasive diagnostic testing helping women in the future who are facing symptoms, especially people who are symptomatic, either having infertility or they're coming in with secondary dysmenorrhea pain?
Well, I think we're going to separate that into two different buckets. The people with symptoms, if we can give them so not every patient with endometriosis needs surgical management. If we can give women with symptoms a diagnosis, then we can discuss options, and it's all about options, including the non-surgical options and the possibility of surgery for treatment. That's one bucket.
Well, how impactful is that statement coming from a MIGS surgeon?
Well, I'm a recovering MIGS surgeon to be clear, but and again, Mark and I have had this discussion a lot, that statements like that have to be made very carefully to the surgical community, because the immediate reaction of the surgeons is, what do you want to do? Take away my livelihood? Well, the answer is no. We want you, the surgeons, to be there for the people that really need surgery. So we don't need and MIGS, for the audience who may not be aware, is minimally invasive gynecologic surgery. We don't need you, the MIGS surgeon, to be doing diagnostic laparoscopy to show that a woman doesn't have endometriosis, or to show that a woman does have endometriosis and you're not going to go treat it. We need to preserve the expertise of these highly trained surgeons for the people that really need them. So that's the one bucket, the symptomatic. And the other bucket is the true screening aspect of, what is screening? As Mark mentioned for HPV, screening is taking a large population of people, and out of that large population of people, narrowing it down to the people that need more things done, whether it's more diagnosis, more therapy, etc. So the possibility, and this is exciting, although this is literally on the cusp, that we may be able to take large populations of girls and women and screen them for endometriosis. And what can we do with that? We can do several things. We can put that in our back pocket for when they decide to get pregnant, to know that they may be at higher risk for pregnancy complications, such as bleeding, placenta previa, miscarriage, preeclampsia, etc. We can also put that in our back pocket for women who down the road may begin to have symptoms and know that it's likely that their symptoms may be due to endometriosis. We can also have that in our back pocket for women who then have trouble getting pregnant and say, yes, your infertility may be related to endometriosis. Where I don't think we are yet, and Mark, I don't think you'd disagree, is if we use this screening test and say a woman has endometriosis and she's not yet trying to be pregnant, she doesn't have any symptoms, do we need to do anything? And I don't think there's any data that doing anything for those women has any value at this point. Do you agree with that, Mark?
No, I would agree. And I think the important fact for people to take home is that when you look at the psychological studies, and there have been numerous publications on this, when you look at the psychological effect of this disease, and again, that's largely been women who are symptomatic.
Right.
95% of the problem, every woman will tell you, 95% of the problem was, I don't know what's wrong with me. The people think I'm crazy, or I think I'm crazy, or my family thinks I'm crazy. That's 95%. And then once they get that diagnosis, it's really only 5% to figure out what to do. Do I do diet, exercise, pelvic therapy, medicine, surgery, whatever it is?
Right.
And I think that's a very important point, is that a good diagnostic test takes you to the point where you now have the control of the choice because you know what it is,
and
more than anything else.
Taking that a step further, the data is incredibly sad and discouraging. And I was just in a meeting this past weekend, the medical meeting of the Endometriosis Foundation of America. And still to this day, the average time from onset of symptoms to diagnosis is anywhere from 7 to 12 years. That's horrendous. And the average woman who has these symptoms sees anywhere from 7 to 10 different doctors before they get a diagnosis. So, cracking that nut is huge.
So, Larry, have we cracked that nut yet?
You tell me, Mark. So the answer is we have the potential to crack that nut. Yes.
Yes. And I think the important, again, if we go to the numbers again, as Larry said, average 8.3, 8.6 years before you get a diagnosis, multiple tests that are negative, you're going to go see the psychiatrist because there's something wrong with you and your family until you finally get a diagnosis. But with the development of this new screening, non-invasive test, that number fell to 30 minutes. So far, with what we have in published studies and what we have in supportive studies from a number of universities around the world. So things are a-changing, as they say.
The times they are a-changing.
Exactly.
Larry,
Are we, Carolyn, you going to put some background music to this podcast? They're a little Bob Dylan right there.
I can put some
Yeah,
in.
Sound of Music a couple of minutes ago,
Well, we need these times to change because I think just for women's quality of life, moving this care up and them knowing what they have is really empowering, because then you can start doing things. So we kind of got through some of the therapeutics. So you were talking about medications that control pain. And actually, I've read quite a bit about combinations that people use. Could you talk about that a little bit? Like, are there
Well,
combinations of pain reducers that are more effective for those people who have secondary dysmenorrhea, where just taking an Aleve or ibuprofen, it's just not working, and that they're at their top level? Yeah, can you speak to that?
yeah. Yeah. Well, by way of full disclosure, and maybe we should have said this before, but I had been in the medical affairs department of a company called Myovant, which is now Sumitomo Pharma America, owned by a Japanese company. And they market a drug called Myfembree, which, as I mentioned, is a combination of three different components. It's a GnRH antagonist called relugolix, but the name of it isn't that important. But it's also got estrogen and a progestin. And the first question people ask is, why in the world would you give estrogen to a patient with an estrogen sensitive disease? And I always say that is a great, great question. The answer to that is, first of all, estrogen levels in the body in women taking Myfembree are lower than they are in women not on any medication. So it still has the effect of decreasing estrogen levels. The reason that you don't particularly want the estrogen levels to totally go away, especially in younger women, is twofold. One is they get the typical symptoms of menopause, which are hot flashes, night sweats, vaginal dryness, etc. And equally, if not more important, is decreased estrogen levels lead to bone loss. The good news is, in the studies of the combination drugs like Myfembree, the bone loss, at least up to 3 or 4 years, has been negligible. So it's sort of, I used to say, it literally is a happy medium between high estrogen levels, no estrogen levels, and what I used to call the sweet spot.
So it's a safer combination, is what you're saying,
Yes.
in some ways, because the
Yes.
symptoms are reduced. I was going to go back to, like, all the way to the beginning, just over the counter pain management medications. If you can take different combinations that you're taking less of each one, but they're sort of attacking the pain from different. I don't know if that's something that you could answer.
I honestly don't know if that, I don't know if that's been studied at
Yeah.
all. Um, I know that there are some combinations out there of a Tylenol or an Aleve or even an ibuprofen plus an opioid. But one of the things we're trying to get away from in all areas of medicine is opioids. So those are not used very much. I mean, and typically, it is. I'm not aware that combinations of things like nonsteroidals are used. It is very possible, though, and this gets back to the individualization, that if Aleve doesn't work for you, and Aleve is naproxen, that ibuprofen might work for you. Not that one is better than the other, but because Aleve might work for you and ibuprofen might work for the girl next door. The same thing with birth control pills.
That answers my
And
question. It's just something that's going to be the first plane of attack, I think, for girls who are trying to manage this. And then once they
right.
realize that they could get screened or have a very easy, rapid diagnosis where there's no surgery involved, that will open up new options for them. But like right now, this is go-to number one. I do
Right.
have one other question. Um, when should they be seeing a specialist? When does it? When is pain too much, and they should be going and getting help?
The answer there is well, first of all, there is no such thing as a certified endometriosis specialist. That doesn't exist. You know, you can go various levels, from a family physician, nurse practitioner, to a general OBGYN, to a MIGS surgeon. The bottom line is, if your symptoms aren't being controlled, you need to find someone who can control your symptoms. Now, there are a lot of general OBGYNs who can use these medications effectively. Not a lot of general OBGYNs are expert in the advanced surgical techniques that are required to deal with advanced endometriosis. But our goal, all of us here and more globally, is hopefully, and we don't yet know if we can do this or not, prevent women from getting to those advanced stages. Because we don't know that it's a linear progression, that if you have early disease and you don't do anything, it becomes extensive disease. One of the paradoxes of endometriosis, which is very frustrating for those of us in the surgical area, is when we do surgery, the extent of disease at the time of surgery has no relation whatsoever to the extent of symptoms. So we will see symptoms, extensive, really, really bad symptoms in women, and when we operate on them, they have 2 or 3 little spots of endometriosis. And then we will see women with very, very few symptoms, and we operate on them, and their pelvis looks like a bomb went off in there with endometriosis. I have an interesting story, and I won't mention names, obviously, but when I was in Tampa, I operated on a young woman who had stage 4 endometriosis. And I did the surgery. I think I helped her. And it turned out she was an identical twin. And her mother brought her twin sister into me, saying her twin sister has very, very minimal symptoms. But because she's a twin, would you consider looking at her? Well, we did an ultrasound on her, and in her ultrasound, she had cysts on both of her ovaries. We operated on her. She had disease just as bad as her sisters, but symptoms that were nowhere near as bad as her sisters. Do we know why? I don't. But
That's fascinating.
that just shows the variability. Yeah.
Well, there's a lot of variability, and something I always want to emphasize is this is a disease that secretes 50 different types of substances that cause different things. So there's 6 different, what they call cytokines. Think of them like hormones. That's the easiest term to think of. And these 6 control pain. And so if you have a lot of disease, but your disease is genetically not secreting these 6, then you could have very advanced disease and never have any pain whatsoever. Similarly, you could have one that secretes all 6 in very high quantities, in which case you don't need a whole lot of disease to have a lot of symptoms. And this is a confounding disease for another reason, and that is there's about 7, 8, 9, 10 studies out there where they did surgery on women. They did laparoscopy. They gave them no therapy. They performed no removal. Patient's closed up, comes back 3 years later, has her laparoscopy again. And in all of those studies, they found that 30% of those women completely regressed and there was no further disease. 30% stayed the same and 30% got worse. So imagine, first you have a disease that has, a billion different varieties essentially because of the cytokines secreted. And then at any given day, it may decide to go away and come back and go away and come back. And so it makes it really hard when we do our studies, especially for drug studies too, is how do you know that something actually worked when you gave them a drug and
Right.
that this wasn't just spontaneous regression? And so I want to lead that into, with this new diagnostic test that we have, could this not be a test that shows the effect of the drug based on the levels that are detected by the test? And could you not use a test like that to say, you're getting better, that's why you feel better, let's keep monitoring you with this test?
Well, And again, Mark, you and I have had this discussion often. That is incredibly exciting. And I know you have some preliminary data to show that that's the case. The more data we get that confirms that, yes, that will be, again, amazing. And it's interesting. And a lot of my MIGS colleagues believe in my, well, it's more than my opinion. I think it's fact now, believe incorrectly that endometriosis is purely a surgical disease. And the only treatment is expert excisional surgery. And further, that if you have surgery and your disease comes back, then by definition, the surgery was inadequate. Well, with what we know about this disease now, that is just blatantly not true.
But Larry, is it the disease coming back or the symptoms coming back after surgery?
Well, both. So
And how do you know?
Well, yeah, no, I think you're right. So what I should have said is that if your symptoms come back, then by definition, the surgery was inadequate. Right. But a lot of these same surgeons, Mark, believe that even if your disease comes back and you have surgery again and they have disease again, then by definition, your initial surgery was inadequate, which is just not true. Because the disease, like Mark said, it can go away on its own. It can get worse. It can stay the same. And the other thing we've learned a lot in the last decade or so is that this is not just a surgical disease of the female pelvis. It is a whole body chronic inflammatory process that literally takes lifelong management. Yes, there are those people that when you treat them, whether it's with surgery or not, they will get better and they will never have symptoms again. That's great. But there are people that have recurring symptoms, and whether you treat them then with medicine or surgery or physical therapy or observation, it's all about individualizing for what that individual patient wants and needs.
But I find that so hopeful.
Exactly.
Like those 2 points that you made. Firstly, that maybe this is not just a surgical disease, because I've heard that a lot.
And I have to interrupt you.
Yeah.
I'm sorry. I don't like to interrupt, but that is in no way to demean the role of surgery.
No,
in management of endometriosis.
But you know what, Dr. Glazerman, I mean, one of the things, the reason why I say it's hopeful, I'm up in Canada and there are people who can't get onto the wait list because the wait list for surgery is out for years. And so they can't get into the clinic. So it really becomes a bleak situation for them. So they have to start looking to travel to get it. And so if I'm really excited about the research that can really start if we're able to more easily manage and collect information about this disease through technology, because we do have the power to collect a lot more information much more easily, non-invasively. And it's not just for endometriosis, it's all about women's cycles, the biometrics of women's cycles, their temperature, we can collect urine metabolites now of many of the hormones. It's just simple for them to do it. So that, and also how you posited that this is a lifelong management for an inflammatory condition. And that also gives hope for women because they can hit it from that surface. Like I said, I always talk like as a patient, what surfaces can you work on if you don't have support from a primary care physician, from a specialist? And these are some surfaces that you can actually impact in terms of taking maybe a combination of painkillers that work for you. getting on the right birth control pill or the right diet, an anti-inflammatory diet, get that kind of thing, managing stress, getting help with anxiety, maybe. So that this is
And Mark made a good point that and I don't remember what the numbers are, Mark, but a large percentage of women, once they have a diagnosis, their symptoms get better, just because they know I'm not crazy and this is not all in my head. And yes, there's something real. Now let's talk. And you mentioned all of the different modalities, physical therapy, acupuncture, diet, stress management. Yes, psychotherapy has a place in that. Not because people are crazy, but because, surgery has a place, medication has a place. All of those things. It is such a multifactorial disease that multimodal therapy is, and we're just starting to learn that. And there are, as Carolyn, I'm sure you know and you're aware, so many endometriosis support groups out there and advocacy groups. And, I went to a fascinating meeting a couple of years ago that's held every year, called the Endometriosis Summit. It's held in Orlando. And I had some objections to the way they did things. But the neat thing was, of the people that attended that, there were about a third surgeons, a third pelvic floor physical therapists, and a third patients. And it was a fascinating mix and interchange of ideas from the patients to the surgeons, telling the surgeons, you're not listening to me, and the physical therapists. And it was fascinating.
I think it's all about empowerment.
Exactly.
The diagnosis gives you. And that gives you the opportunity to decide your course of therapy. But it also gives another, I think, very important point. And as we get closer and closer to this, there is no one, whether you're a pelvic physiotherapist, a GP, a primary care physician, a nurse practitioner in the provinces out in the sticks somewhere, no matter what you are, if you have a test that gives you a quick diagnosis, you have the ability to sit and go through the laundry list of what do you want to do now? How do you
Right.
feel? Where do we need to be? And like the physiotherapists in particular they're very concerned because they know they're doing all this physiotherapy work. And even the literature shows if they don't know that it's endo, their effects are very limited in what they can do to help. But if they know it's not, boy, they can have an amazing effect with pelvic floor dyssynergy. Even if it is endo, they can make a lot of different changes that'll make a difference. And so I think the ability to get the disruption of I've got a diagnosis as opposed to not having one, I think becomes really, really important. And I just want to add a couple of things. We know from studies that have been done locally here in Maryland, where we are, if you are a surgeon and you've removed all the disease that's visible, that's active, your test will become negative if you do one of these diagnostic tests. And that gives, for the very first time, the ability to follow and say, did my disease come back or do I have something else causing my pain? That's an important decision point. And we know, and I'm going to give a shout out to Dr. David Griffiths over in the UK, who is a surgeon, an endometriosis surgeon, as well as a gynecologist. And he's the one who, using the same test, found out that, what was the drug? I always mispronounce it, Larry.
Denagest. Oh,
No,
relagolix.
the relagolix. He found out that if the teenagers have a positive ENDOSURE test, they will predictably respond to the drug and their pain will diminish or go away. And he matched that to decreases in the levels seen on the ENDOSURE test. So he's literally able to follow people along and decide, do you need more? Do you need less? Should we switch you to another drug? The power now
Or should we
becomes,
do surgery on you?
or should we do surgery? Because you know what? It's not working.
Right.
You're
Right.
not getting anywhere with it. And I think that these are such important choices. And then you mentioned Denagest. I want you to talk more about that, because that literature that just came out, when we talk about is there something that can kill this disease? There's something really interesting.
Well, Denagest is a progestin that, for reasons totally unbeknownst to me. In the US, it's available as part of a combination birth control pill. And most birth control pills are combination, estrogen and progestin. It's not a very widely used birth control pill in the US. In Europe, and I don't know about Canada. It might be
In
available in
Canada,
Canada
it's
for all I
called
know.
Visane.
Yes, I think it's called that in Europe also. So it's available Dinagest alone, and Dinagest. The studies on Dinagest, and I've done some consulting for some companies, and I've said to them, you need to bring Dinagest to the US. And they say, yeah, maybe, but it is a progestin, and it has the two things. And the second one, I think, is the one Mark wants me to get at, but has incredibly good results for endometriosis related pain. Again, we don't know if it affects the lesions of the disease. We would guess that it does, like that any of these, the relugolix, the Dinagest that they do, but that hasn't been shown or even claimed. But the great study that Mark shared with me a month or two ago about Dinagest is we talked about the pregnancy complications with endometriosis, that women who've been treated with Dinagest, who then get pregnant. Now, they obviously don't take it while they're pregnant because it's contraindicated during pregnancy. But women who've been treated with Dinagest for their endometriosis have much lower incidences of these pregnancy complications that are related to endometriosis. And that is mind-boggling because I don't believe, and Mark, I don't believe that even the surgical literature shows that after surgery, you have lower incidences of these adverse events. Do you know that, Mark?
Correct. No, that's correct. Surgery has no effect on postpartum complications.
But Dinagest does. And that's why I've been begging some of these companies to bring it to the US. Again, my surgeon colleagues might not be very happy, but again, that's not obviating the need for surgery. That's, and there are studies out there with post-operative treatment with, there's some ongoing studies. I know when I left my event, there were some investigator-initiated studies looking at GnRH antagonist after surgery for prevention of recurrence, prevention of pregnancy complications, et cetera. I don't know the status of those at this point, but again, that theoretically at least would be huge.
Well, if we stay with the Dinagest for just another second, what's interesting is I don't know if I shared the study with you, but the Chinese did an amazing study where they determined that Dinagest actually shuts down the ability of the endometriosis tissue to reproduce. So it stops the nucleus from being able to divide, and therefore the cells can't divide. And so it just dies from what we call apoptosis, natural death, after a certain number of days. Now, and what I want to ask you though is, I've mentioned this to a number of MIGS surgeons like yourself, and some of them have made the comment that they in their memory, this is all anecdotal. There's no, there's no formal study. They said that it's very interesting because the patients that they operated on who had Dinagest, when they got in there, it's like the endometriosis tissue was just necrotic, dead, dying an evil death. Have you experienced that? Is that possible?
Well, the answer to the second question is yes, it's possible. I haven't experienced it because I haven't had the ability to use Dinagest. I have had an anecdotal discussion with a surgeon. This was fascinating. And it's interesting because this is with, when I was with my event, with my Fembry, we had an advisory board of surgeons. And I don't remember the surgeon's name. He was from the Midwest somewhere. He had a patient who had surgery with another physician. And all he did was look. He found significant endometriosis, didn't resect any of it. He put her on a GnRH antagonist, actually the competitor to our drug, for several months, and I don't remember how long. And then this doctor operated on her again. And I'm not sure if it was because her symptoms came back. I don't remember all the details, but he had photos from the original surgery and the second surgery, and the disease was almost gone. So that was at least anecdotal isn't evidence, but I'll say anecdotal evidence that maybe these drugs do impact the disease itself, more than just the symptoms.
That actually goes right back to one of your first statements about therapeutics, that right now, we don't have a drug that actually treats endometriosis, but maybe
we don't have a drug. We don't have a drug that we know treats endometriosis.
What's interesting when I looked at Visane is, there's a generic already available. So does that mean just, from where I sit, is that going to be difficult to get additional clinical studies done on something that's already lost its patent? It's generic already, much lower cost, yet it shows promise.
So there's two parts to that. Yes, it might be more difficult for and I don't remember what company marketed it, the brand Visane, for them to fund studies, since their revenue from the drug is probably precipitously going down. But it might make it easier for people to use it. Again, because it's gone generic. It's interesting. I have a colleague at a drug company, who I've spoken to, who is in the US and actually has literally has taken Dinagest, gotten it from Canada, and taken it. And she said it helped her. Now, again, that's N of one, but.
So, one of the things that we keep echoing here that, Larry, you covered in the very beginning that I want to really emphasize to people is that this is your personal genetic disease. This is yours and yours alone. You cannot compare yourself to anyone else. Maybe if you have a daughter, yes, that can be very similar. And we actually see this with the ENDOSURE test. We see similar fingerprint type patterns in direct family members. But this is about a disease that's so different. It introduces this concept of, and again, why did this one patient take Dinagest and it went away and another patient it didn't? Subtypes of disease. There are so many subtypes of this disease. It's like, just never give up. Find your way, find your path that works for you, and don't stop because you run into a wall with one drug or one therapy or surgery. You just keep going until you find that special sauce that works for you, and find a doctor or another support person,
provider of some sort.
Exactly, who understands this and is going to work with you and not stop and throw their hands up and say,
and that speaks even more to the difficulty of this disease. Now, most diseases are variable in expression, etc. But think of, if, let's say, hypothetically, all endometriosis behaved the same, we still would have to look at these different therapies and whatever. But knowing that of it's 1.7 million in the US women.
17 million?
Is it 17 in the US?
No, 17 million who have the disease in the US.
17. Okay, I misplaced the decimal point. Sorry. But of those 17 million, you got 17 million different variations of this disease.
Exactly.
Which makes it even that much harder to understand and to study. And this conference I was just at this weekend, they were, some of the presentations, they were amazing. They were literally down to the cellular level of these cell. And I mean, I didn't understand half of what was presented in this meeting. It's just such a frustrating disease. Again, you're talking to two old bald guys here. Think about how frustrating it is for these women.
Dr. Glazerman.
As frustrating it is for these Old bald
Well,
guys.
I wouldn't say that. We do only have a few more minutes. Do you want to end with maybe, the strongest point that you wanted to bring across? I know we never even talked about MIGS. We probably didn't even get through all the therapeutics because there were so many questions, but I just wanted to give you the floor for the last 2 or 3 minutes and then we'll have to, end for the day.
Sure.
Yeah.
Sure. I think the 2 points that ought to be brought up, and we've danced around it a little bit, whatever, is you have to think of 2 different things with this disease. First is the diagnosis, and then is the management. So in terms of diagnosis, to date, the only definitive diagnosis we've had has been an invasive surgical procedure. Before we get to ENDOSURE, which is revolutionary, there are other things that are coming and almost there. They're doing a lot with ultrasound. Unfortunately, with ultrasound, in order to do it right, it has to be in a few very, very, very specialized hands. We're doing better with MRI. So revolution in terms of diagnosis. And I really do believe that ENDOSURE, it's been studied quite a bit. It needs a lot more study, but it's revolutionary. In terms of management, I think the message to the women out there is, as Mark just said, this is your disease. Your disease is different from your neighbor's disease. And you need to find providers at every level, whether it's a nurse practitioner, a family doctor, a physical therapist, an acupuncturist, a gynecologist, a surgeon, whatever, who's willing to stick with you and listen to you through all of the machinations that this disease will take you through, probably for your whole life.
Thank you.
I hope that helped.
That was so powerful, especially during Endometriosis Awareness Week, which is when we're filming this. Thank you so much for being on our podcast, Dr. Glazerman. I hope we can have you back, eventually. Sure. We can maybe talk about MIGS. That's it for today. Thank you for listening, and we'll be back for another interview very soon. And that ends another episode of Endometriosis A to Z, where we feel knowledge is power when it comes to managing endometriosis. We'd love to hear from you about topics you want covered. If you have questions that you need Dr. Noir to answer, you can email us directly at hello@endodiagnosis.com. Until next time, stay informed, stay hopeful, and keep advocating for your health. See you in the next episode.